We have discussed antihypertensive drug in our previous video, so this is the second part of that video, in which we will first discuss about the drug which will increase your potassium efflux, and if potassium efflux increases, then that will lead to hyperpolarization, and hyperpolarization lead to vasodilation. So mechanism of these drugs is same. K plus influx will increase from smooth muscle or blood vessel, that will cause hyperpolarization and that will lead to vasodilation. The first drug in this is hydralazine. Hydralazine mechanism of action is same, that is increase K plus efflux, that will lead to vasodilation. And another mechanism is also proposed for the action of hydralazine, that it increases anosynthesis, that will also lead to vasodilation. Now coming to the pharmacokinetics of the hydralazine, so it can be given orally or intravenous. This is lipid soluble drug, so it is mainly metabolized by liver through acetylation. Acetylation is done in the metabolism of hydralazine. Clear? Now another important point, that metabolism of this drug has pharmacogenetic variation also. Okay, in some person there will be fast acetylation, in some there will be slow acetylation, so there will be pharmacogenetic variation seen in the persons. Now action of this drug is 6 to 8 hours, and it is safe to use in pregnancy. Okay, so it can be given in pregnancy induced hypertension. Clear? Now this is important point, this drug hydralazine can be given in pregnancy induced hypertension. Coming to the effects, so first, it is also used in treatment of hypertension crisis because it has fast onset. Okay, if in hypertension crisis we give this drug intravenously. Now it can also be used in maintenance treatment of hypertension. Okay, this will lead to these drugs leading to vasodilation. Vasodilation means decreasing peripheral resistance. Okay, and one more important point here, two important points I need to mention here, that decrease in peripheral resistance will lead to reflex tachycardia. Okay, and so to counter this effect, to counter this side effect, that is reflex tachycardia, we should also give beta blocker along with hydralazine. One more point, that decreased peripheral resistance will increase blood entry into tissue because of the decreased peripheral resistance. So there will be decreased renal blood flow because there is increased blood into tissue. So renal blood flow will decrease. This will lead to activation of RAS mechanism, and this RAS mechanism lead to increased water retention. So there will be chances of edema. This is another side effect. Okay, there will be chances of edema. So to prevent edema, we also give diuretics in low dose. So hydralazine combined with beta blocker combined with diuretics in low dose to overcome these two side effects. Clear? Now this is safe to use in pregnancy, so given in hypertension crisis and pregnancy we have discussed. It is also used for maintenance treatment of congestive heart failure. Okay, hydralazine usually combined with isosorbide dinitrile. Okay, we give for maintenance treatment of congestive heart failure. Hydralazine reduces afterload, that is leads to vasodilation, and it will reduce afterload, that is aortic pressure. And this isosorbide dinitrile, it is mainly vasodilator, so vasodilator will lead to decrease preload. Okay, that is in diastolic volume. So these drugs, the hydralazine combined with isosorbide dinitrile, is given for maintenance treatment of congestive heart failure. Now coming to the next point, side effects of the hydralazine. So first side effect is hypertension, that is decrease in BP. Second, there may be chances of orthostatic hypotension, but that there is less common side effect. Okay, because they are only arterial dilator. One more point I need to mention here, that hydralazine is mainly your arterial dilator, so they have no effect on veins. So if there will be no effect on veins, then end diastolic volume remains normal, so cardiac output also remains normal. Okay, so there is less chance of orthostatic hypotension. Clear? So medicine responsible for vasodilation have side effect as orthostatic hypotension. This drug has no effect on veins, so there will be very less chances of orthostatic hypotension. Now the next is that these drugs are metabolized by acetylation, as I have told earlier. So it have SLE like symptoms. Okay, systemic lupus erythrosis like symptom, and this is known as drug induced lupus. Clear? This mechanism behind this we will discuss in our video of systemic lupus erythematosus. Now as this drug is causing vasodilation, this will lead to increased blood supply of hair follicles, so it will increase proliferation of hair follicles. This will lead to a condition known as hirsutism, that is hypertrichosis. Clear? So these are the side effects. The first one is decreased BP, orthostatic hypertension may be there. Okay, but it is very less common here. Acetylation lead to drug induced lupus, and vasodilation leading to hirsutism. This is very important, hypertrichosis. Now the next drug is your minoxidil. So minoxidil mechanism of action is same. It will increase K plus efflux, that will lead to vasodilation. Its pharmacokinetics, it can be given orally or as well as topical route. Now oral route is when minoxidil is given in oral route. Okay, we use prodrug form, and once it reaches liver, it is converted into minoxidil sulfate, that is the active form. Clear? Now it has slow onset, so used for maintenance treatment of hypertension, not for hypertension crisis. If it is given topically, okay, it will increase hair follicle growth. Okay, so it is used in treatment of androgenic alopecia. Clear? We use topical lotion that contains 1 to 5% of this drug. Okay, used topically in the treatment of androgenic alopecia. So this is important point for minoxidil. it is quite unsafe in pregnancy, so not used to in giving pregnancy induced hypertension. Rarely this can also cause pleural effusion and pericardial effusion. This drug has side effect which is very rare, that is pleural effusion and pericardial effusion. Now coming to the next drug, that is dioxide. So it is mainly given by IV route. Mechanism of action is same, that is increase K plus influx, okay, K plus influx in beta cells of pancreas mainly. Dioxide mainly works on beta cells of pancreas where it will increase K plus efflux. That will lead to hyperprotection, that will lead to decreased insulin secretion. So this is best drug for hypoglycemia associated with insulinoma. So dioxide is best drug for hypoglycemia associated with insulinoma. Clear? And this is contraindicated in pregnancy. So this is about K plus efflux increasing drugs, that is hydralazine, minoxidil and dioxides. Dioxide is for mainly hypoglycemia associated with insulinoma. Okay. Now coming to the NO donors. So mechanism of action for NO donor drugs is that they will donate NO, nitric oxide, and this nitric oxide inhibit conversion of myosin light chain into myosin light chain phosphate. Okay, and if myosin light chain phosphate is not formed, then there will be no interaction of myosin with actin, then there will be no contraction, and that will cause vasodilation. Okay, there will be no contraction of muscle, that will cause vasodilation. So NO donors mechanism is this. Okay, inhibition of formation of myosin light chain phosphate. Now coming to the drugs which are involved in this. So the first drug is sodium nitroprusside. Properties of the sodium nitroprusside: this is the most efficient and strongest vasodilator. This is very important point. Most efficient and strongest vasodilator is your sodium nitroprusside. It will dilate both arteriole and venules. Second important property, it can be given by IV route, so it have fast onset. Now it can be used for the treatment of hypertension crisis, and this is the best drug for intraoperative hypertension crisis. This is the best drug for intraoperative hypertension crisis. But when we give at the time of operation, we have to look for monitoring this drugs amount. Okay, so monitoring is also required because it has fast onset and it can dilate both arteriole and venules, so its monitoring is very important. Clear? When given IV route, fast onset, and when we will stop this drug because of less T half, okay, it has also fast offset, so monitoring is very easy also. Okay, this is highly lipid soluble, so tissue entry and CNS entry is easy, and that will cause vasodilation in CNS and other tissues also. Due to cerebral vasodilation, headache is side effect. Okay. Now liver metabolism by binding to thiosulfate group. This drug is metabolized in liver by binding to thiosulfate group. How? So this is sodium nitroprusside. It contains cyanide group. It reacts with thiosulfate and lead to formation of sodium thiocyanate. Okay, this thio group will combine with the cyanide group which is present in nitroprusside. So this thio group combines with this cyanide group which is present in nitroprusside, lead to formation of sodium thiocyanate. Sodium thiocyanate is formed, and this is inactive. This is active. This sodium thiocyanate is inactive, and this is eliminated by kidney. So its elimination depends on kidney. So in chronic renal failure, sodium thiocyanate start accumulating inside the body. The sodium thiocyanate in chronic renal failure starts accumulating inside the body, and the sodium thiocyanate will compete with sodium iodide for entry in thyroid follicles. The sodium thiocyanate will start competing with sodium iodide for its entry in thyroid gland. So it will block iodine entry. Okay, it will block iodine entry inside the cell. So this can cause acute hypothyroidism as side effect. So very important, cerebral vasodilation as side effect, acute hypothyroidism as side effect. So this is a very important point here. Clear? Now this is unstable drug, okay, because of the less shelf life, so get denatured after coming in contact with sunlight. So these drugs can't be stored in hospital, so every time we have to prepare fresh solution of this drug. Now if dose increases, then liver metabolism may get saturated. If the dose of sodium nitroprusside will increase, then liver metabolism may get saturated, which lead to cyanide accumulation, which then bind to hemoglobin and form cyanohemoglobin. Okay, if cyanide accumulation will be there, then this will bind to hemoglobin, lead to formation of cyanohemoglobin, and if cyanohemoglobin is formed, then this will decrease your O2 carrying capacity and lead to hypoxia, and this is known as cyanide toxicity. Clear? Cyanide poisoning is different from cyanide toxicity. Now 2 to 3 methods are there to prevent this cyanide toxicity. The first one is use of hydroxycobalamin. Okay, hydroxycobalamin is given through IV because this cobalamin part has very high affinity for cyanide. This cobalamin part has very high affinity for cyanide, so that they both will combine and form cyanocobalamin, okay, which is non-toxic in nature. Clear? So you can use hydroxycobalamin. The next one, you can use sodium nitrite plus sodium thiosulfate. What is the mechanism? So this hemoglobin, which is in Fe+2 state, will be oxidized by sodium nitrite. It has +2 charge, it has +3 charge. This sodium nitrate will oxidize this hemoglobin iron +2 and +3 and then form methemoglobin. this will form methemoglobin, and this methemoglobin contains iron +3, so it has increased affinity for negative charge, that is cyanide minus, so cyanide minus combine with Fe+3 and form cyanomethemoglobin. But it will form cyanomethemoglobin. Okay, and then sodium thiosulfate will react with this and form sodium thiocyanate, and methemoglobin will be metabolized, and this sodium thiocyanate will be eliminated by kidney. Okay, so cyanomethemoglobin, methemoglobin separated, and this thio will combine with cyano and form sodium thiocyanate, which will be eliminated by the kidney. Okay, now, and there in normal, that is 15 gram per dl. Okay, and 3 to 4 gram per dl is converted into methemoglobin. So we are successful in preventing about 11 to 12 gram of hemoglobin in normal state. Okay, clear? So this is the second method, that is use of sodium nitrite. Although some hemoglobin is undergoing metabolism, but we are able to prevent about 11 to 12 gram, that is enough for your survival. So first one is hydroxyl cobalamin, the second one is sodium nitrite plus sodium thiosulfate. Moving to the next. Okay, we can also give O2 therapy. Okay, this is the third method. Now coming to the next effect of our drug sodium nitroprusside, that it can cause venodilation. As we have discussed, this nitroprusside has effect on veins and arteriole both. So venodilation, which will cause decrease in preload, that will cause decreased cardiac output. Clear? There will be arterial dilation. This arterial dilation will decrease your afterload, and this decreased afterload can increase heart rate, increase cardiac output. So due to venodilation, there is decreased cardiac output. Due to arterial dilation, there is increased cardiac output. So they will neutralize each other effect. So very less risk of orthostatic hypotension is seen in the case of sodium nitroprusside. So this drug is used during surgery. Okay, because of monitoring MEG, because of less chances of orthostatic hypotension. So this is all about your sodium nitroprusside. Now we will move for the next drug, that is nitroglycerin. So mechanism of action for nitroglycerin is same, that it will increase NO, that will cause vasodilation, and nitroglycerin predominantly act as vasodilator. So it will decrease preload, and if preload is decreased, then heart has to contract less forcefully, so O2 demand will be decreased. So used for treatment of angina. So nitroglycerin is used in the treatment of angina. Clear? If given in high dose, it can also cause arterial dilation, so treatment of hypertension crisis and hypertension crisis with angina and MI. So this nitroglycerin can be given in treatment of hypertension crisis along with angina and MI. Now coming to the treatment of hypertension, we have discussed all the drugs which are involved in hypertension. Now we look for treatment. Okay, how we will treat the hypertension patient. So there are two types of treatment, either maintenance treatment or hypertension crisis treatment. So for first we will discuss for maintenance treatment. So it is again divided in two parts: young patient less than 55 years plus non-black. Okay, young patient which is non-black, less than 55 years, we use different drugs. For old patient more than 55 years and black patient, we use different drugs. So first coming to this, so first we will give ACE inhibitors mainly. Okay, ACE inhibitors, and you can also use angiotensin receptor blocker if there is cough as a side effect. Okay, or angioedema as a side effect, which we have discussed in ACE inhibitors. So if there is a side effect, then you can use angiotensin receptor blocker, but this is first choice. Now there will be two conditions: either hypertension will be controlled or not controlled. If controlled, then continue same treatment continue. If not controlled, then we will look for next step. First we'll look for this old patient black. So we usually give calcium channel blocker. Okay, that is dopamine containing drugs. So we give calcium channel blocker. There is two conditions: either not control or control. If controlled hypertension, then continue the same treatment. If not control from this side, not control from this side, we give ACE inhibitor. Okay, we will combine these drugs. We are giving ACE inhibitor to this patient, we are giving calcium channel blocker to this patient, then we will start giving both ACE inhibitor along with calcium channel blocker to this patient, ACE inhibitor plus calcium channel blocker to this patient. Okay, so this is, now there will be two conditions: either we will control hypertension, we will control or not control. If control, then continue this same treatment. If not control, then we add thiazide along with this. So we give ACE inhibitor, calcium channel blocker and thiazide. Clear? And there will be two conditions: if it will control, not control, then continue the same treatment. If not control, then it is known as resistant hypertension, and in resistant hypertension we use aldosterone receptor antagonist, or we can use beta blockers, or we can use clonidine types of drug that acts on central nervous system, that is alpha 2A stimulant. Clear? Now we use beta blockers when we want to decrease heart rate. When we want to decrease heart rate, then we use beta blockers. When CNS component is involved in hypertension of that patient, then we use clonidine like drugs. When we have to monitor K+, as ACE inhibitors are already given, okay, and we use aldosterone receptor antagonist, but we have to monitor K+, because we are already giving ACE inhibitors. Clear? So this is your treatment of hypertension. So you, in this way you can treat maintenance. This is for maintenance treatment of hypertension. Clear? One more point: these three drugs is known as first line of drug for hypertension. Now coming to the treatment of hypertension crisis. So first we will define what is hypertension crisis or hypertension emergency. So more than 180 by 120 blood pressure plus end organ damage. This is the hypertension crisis. If BP is more than 180 by 120 without organ damage, it is known as hypertension urgency, and no fixed guidelines for their treatment. So coming to the treatment of hypertension crisis. So first choice of drug is sodium nitroprusside. Mechanism of action we have discussed, increasing nitroxide, and this is the most efficient because they can dilate both artery and vein. Dose is intravenously if you are giving 20 to 300 microgram per minute, and side effect is just we have discussed cyanide toxicity and decreased T3 level. Next is your nitroglycerin. You can also use nitroglycerin. Method of action is same, that is nitroxide increase, that is ventilation. Dose is 5 to 20 microgram per minute. Treatment in hypertension crisis associated with angina MI. Next we can also give hydralazine. Method of action we have discussed, increase K plus efflux. Dose is 10 to 20 milligram. Either you can give orally or IV. Treatment hypertension crisis in pregnancy. This hydralazine is usually given in hypertension crisis in pregnancy. Then esmolol beta blocker, IV giving 0.5 milligram per kg of the body weight. Treatment is aortic dissection with hypertension crisis. Then you can also use levotalol, that is beta and alpha blocker. This is the best drug for hypertension crisis in pregnancy. Levotalol. Okay, this is the best drug for hypertension crisis in pregnancy. It is both beta and alpha blocker. Then you also can use prazosin when hypertension crisis is associated with insect bite. You can also use phentolamine for treatment of cheese reaction and clonidine withdrawal syndrome. You can also use phenoxybenzaimine, nicardipine. Okay, this is most preferred in hypertension crisis, nicardipine. You can also use enalaprilat. Okay, this is the active metabolite of enalapril. Captopril also used. Ganglion blockers you can use, loop diuretics, phenoldopam. So these are the drugs we can use. Okay, so this is all about the hypertension. So thank you for watching. You must watch both videos of hypertension. Okay, you will get